so part 2, we're rolling another day back to back because Mike had personal hygiene and went to the dentist yesterday.
My teeth are all nice and clean, and I guess it's one of the things I make a priority. I think that's my one time a year that I miss work.
So, anyways, we are continuing begrudgingly. I was going to be home today before Thanksgiving, but here we are. Too much stuff to cover on the call letter, so we just thought we would kind of wrap at least the tail end of our thoughts on the executive summary and everything else. And I would already just say, even in a day, I was already online on LinkedIn, Facebook groups, everything online. And look, I would just tell everybody, agents are all rabbling, pitchforks are out, torches are out. Everybody's talking about all the different elements of the call letter. I just want to kind of remind everybody just to have some context and understand that, right now with like Becerra and this administration and the leadership there, essentially as soon as RFK, who's the head of Health and Human Services, of course, barring the appointment, which I don't think, is not going to happen, and same with Dr. Oz, those are the two people slotted to be over Health and Human Services and CMS specifically. They are going to come in with a whole new framework, essentially, and vision of what they want to really actually happen with HHS and with CMS. And so I'm just telling everybody, take everything with a grain of salt. I don't think at this point in time people have to be in a full panic. They're going to literally walk in, take that call letter, and practically rip it in half.
And just high level, if everybody remembers too, we talked a lot about it on the podcast earlier in the year, but we had the Chevron doctrine go down, get defeated by the Supreme Court. And, just as a reminder, the Chevron doctrine essentially was, and that being defeated was limiting power from government entities like CMS to essentially legislate and make these rules without legislative process. Yep. And so already, this is kind of the last grasp, in my opinion. And as we've just been talking about this call letter and reflecting on still the past 2 years, I'm just reminded at how this is not normal. This is not how it used to be. This is not how it's been, even in prior administrations, R or D, where you've just had such a deluge of information and regulations and just the absolute administration and all the details that how granular they want to get with these rules. Like you're saying, it's almost going to be not necessarily a moot point, because there's still going to be some things to wade through. But and I will give some credit to credit's due. I think there are some positive intentions in some of these proposed guidelines. Yep. But I just don't know that we need to be like force feeding them down the industry in a form of like really aggressive oversight and regulation. So,
yeah. And to your point, I think there are some good things that they're going to keep. I actually sent an email example to Mike yesterday when we were done shooting the podcast of literally a carrier who sent out an email. It's November, what is today, the 27th? And so on November 26th, they sent out an email saying, hey, as of January 1st, this pharmacy network's not going to be in network and par. So, go to this network pharmacy instead. And I'm going, this is a perfect example of actually what I think is a good rule to say, look, PBMs and carriers, who's going to be par, for the next calendar year. You don't have to wait until November 26th to tell brokers after they already spent a month and a half in the marketplace telling consumers that this network is par. You can go there to pick up your prescriptions. Oh, just kidding, I'm a liar. You can't. I think that's a great rule. Like, I think that makes sense. I think that's good for the consumer. I think it's good for the broker. Those ideas and concepts are definitely good and warranted. So, again, we talked about that, a little bit on the podcast yesterday and literally saw an example of it just within an hour of shooting.
Yeah, but again, like, we don't need to like regulate and legislate in all things, because again, the industry already has a course correction for that, which is, that's the whole point of OE, of open enrollment on the Medicare side of things, was just in case things like that happen, you have one more additional option, and you've always had that to make kind of a correction of a change of plan or things like that. So right. I'm just a big fan of letting the market handle these issues and letting the free market create these solutions. And I think that, if you have the right framework already, we're going to operate in the best intention of the Medicare beneficiaries anyway. But let's get into some of these details. And
let's start with where we finished yesterday with mental health. And I think this is a big thing I didn't see people talking about yesterday online. Like I really don't want to take an official position about whether we should be enhancing or not, mental health benefits in Medicare. I think anybody who's been in the industry knows that mental health, whether it be in an institutional setting or outpatient setting, has not had great coverage under Medicare, right? I think that's the reality of it. My position of it is if you are now taking the position that you want to enhance and require the services like more therapy visits, outpatient consultative services, inpatient, you want to have a more robust coverage for mental health care, which is what they're obviously proposing in the call letter. They're talking about like the national mental health crisis and everything else, which again, that's fine, but where's the money coming from is really my position. And in the call letter, they kind of acknowledge and say, you're going to have this as part of your overall bid, essentially. So everything that we're hearing from CMS is less dollars going to insurance carriers or payers. So not more, there's less. So again, if you're now going to require, kind of beefing up or enhancing the mental health services, you are going to have to take those dollars away from other benefits in the overall benefit structure of a plan.
Yeah, so, I mean, mental health and behavioral health in general is at a crisis point in the country anyway, and it's not just for Medicare beneficiaries and Medicaid recipients, it's everybody, right? We have an absolute mental health crisis in the country, and then you have way too few mental health professionals, behavioral health professionals, neurologists. It's a big problem for everybody. I don't care what state you live in or what major metro, and the further on down the line or the hierarchy of insurance needs that you have, the more difficult it gets. So of course you have, especially with the duals and this, the more social determinant of health needy population, it's hard to get people access to actually good quality care. And you see that across all aspects of our healthcare system, right? You talk about veterans always needing access to good quality behavioral mental health. And, even if you have, traditional insurance through an employer or something like that, private insurance, it's not great. It's hard to get access to care, neurology, things like that. The more specialized and the more nuanced the specialty, the harder it is. So, of course I think we need to tackle that. That's a whole, separate podcast that we could work on. But I think what I'm saying is that's easier said than done, right?
Well, correct. But again, it all comes back to where do the dollars just materialize from, and to do that is more the question. So I think that's more, everybody needs to either understand and agree that we're now going to start including that into an overall benefit structure, and that, essentially you're going to have to increase your overall MOOP on medical for MA plans, or you're going to have to increase your specialist copays, you're going to have to increase your ambulance, your hospitalization, or somewhere you're going to have to pass on that cost sharing to the consumer in order to create space in the benefit structure for mental health. So that's just my thing in the idea. And I more, on the podcast want to talk about the concept of what's being introduced in the call letter and what that means like in practice, right? Mm-hmm. So that's not enough probably on mental health. But the other thing, of course, duals, they did talk about having one integrated ID card for both Medicare and Medicaid. I actually think that makes sense. It's easier said than done, of course, because we can't even get some states to have very good lookups, like that don't even work with Laser or YPro or Change Health. Even trying to get some state databases to, sync up and look at somebody's, level of eligibility, whether they're full duals, partial duals, states don't even do that well. So the idea of saying, hey, let's get an ID card where it shows their Medicare and Medicaid in one. Love the idea. Practicality of actually doing it and making it happen and the cost to do that, very, very...
It seems like a fantasy right now because, we just lived through the whole year of the Change Health hack, which was the centralized service to look up each individual state Medicaid IDs, and each state has a different process, a different different qualification.
Different,
that seems
really
like a really hard
FPL,
ask.
Yeah, give your FPL, but different qualification levels too.
So to somehow marry those together and have one member ID, I mean, I guess that seems kind of cool. But you know, when you take somebody's Medicaid ID anyway, and then you enroll and their Medicare ID, and you enroll them in a dual plan, they get a unique member ID anyway. So
think about this. We've been talking about it for years. Why don't you use blockchain or crypto for your medical records? And when you access a hospital in one health system and then a doctor that's a standalone private doctor, and then you access a different health system or ACO, having all of your medical records on blockchain or crypto, could it all be done? Yeah, it could be done. But what's being, there's too much red tape. There's too many silos. There's too many different prerogatives, and people with agendas, they don't always get aligned. And so I think that's going to be one of those things that, again, is going to be, there's going to be some barriers to get that accomplished, I think, in my opinion. The other thing that was a great idea, I think, in theory, was to have one single HRA. So they're proposing, if you're all familiar with the health risk assessments, it's, initially when you're enrolling in a plan, it's kind of asking certain key questions, identifying healthcare needs, trying to plan ahead if this person's really healthy. Do they have chronic conditions? Do you need DME? Do you need, a concentrator machine at home? Do you need a walker, a wheelchair? Do you need, there's a lot of different, based on somebody's health status, resources that they would need. And that HRA helps establish that baseline, because a carrier does not know until they start seeing claims data what is going on in that person's life and how to best serve them. So that's the idea of the HRA, and to have one for both Medicare and Medicaid. I think the idea of condensing that and simplifying it is good. Would love to see how they actually
also having a standardized HRA form, because they're different from carrier to carrier, and some of them are very exhaustive and annoying to go through and ask, somewhat weird questions, and then others are more pared down.
Well, let's be realistic too. Some of the carriers I've spoken to say, yes, we actually need that HRA data because we pipe it over here, and this is what this does, this next action, it triggers this on our end. And I have other carriers who tell me, yeah, we don't do anything with the data. We're not sophisticated enough within our systems, and we should be doing it, but we're not. So we basically pay a broker HRA just so we're not left behind from a compensation perspective. But we don't do anything with it. So, I mean, you have to understand you have different, again, levels of sophistication within internal systems at different carriers. And so to go, are all these I'm sorry, some of these states are a total shit show. And so for me to have confidence that their state Medicaid is going to be able to standardize that, ingest that, and work, it's again, it's a good idea. I would love to see how it gets done.
One day everybody will have their unique identifier with their health record history secure on the blockchain.
And I will still be saying, like, as we're doing this and talking about the idea of it and implementation and practicality, if somebody wants to kind of chime in and say, oh, hey, Dan, there's actually like all this stuff behind the scenes that's happening, and this is actually a reality because of X or Y or Z, please tell me. I would love to be enlightened,
Yep. Yeah, the next thing was they just put a whole provision in there. Section 13 just says MLR, medical loss ratio. Just toss that out there like it's a little line item thing,
It was like, well, this is a little thing, but then you start treating it and you're like, whoa, hold on. You start using the term MLR, medical loss ratio, and it's like a trigger word, and actually it should be, because, if you were even looking, I was looking at Aetna's earnings the other day, and did you see their MLR on their Q3 reports? 95.2% on MLR, which is like,
things are not looking good for them, my friend.
That is atrocious, just for people. Really bad. But so when you start going through MLRs, they base bonuses off of, MLRs and anything. Anyways, so they want to establish a new audit process for appeals for compliance on the MLRs. They want to amend a lot of different regulations. They want to codify different rules. They want to redefine things. I'm going to cut to the chase of it. They want to change like the numerator when they calculate out the bonuses. In essence, what they're saying is they want to reduce the amount of bonus payments that they're giving to carriers, for star performance and for MLRs. And so they said it's to reduce excess payments going to carriers in their bonuses. And I kind of go, it's actually been the opposite in the last year. If you look at it, they were so aggressive and heavy-handed in their cut points, in their two-key formula, in their guardrails, and everything. They underpaid a lot of carriers and were sued multiple times and were keeping receipts. They didn't win any of those lawsuits. And so the carriers had to fight and scrap and sue to even get paid what they should have been based on their own compensation rules. So I think this is obviously trying to set the table to pay them less on bonuses next year. Well,
MLR is really the formula for how the whole thing works, right?
85-15.
Yeah, and if we can't figure out the MLRs, none of the Medicare Advantage program just can't work efficiently. We can't provide the benefits that we need and have the carriers perform their duties that provide the base level benefits of Medicare. Plus, if we can't figure out the MLR to be where they can still operate and then make a profit, a small margin. And usually the margins, as a reminder, on these MLRs that these carriers are making are very small, 2, 3, 5% margins at best. And so, these carriers are already trying to thread this needle. Right. And that's where their profitability, when you start talking about the law of large numbers, and when, Dan was mentioning that, did you say it was 95% or 92%?
95.
So, they're about 10% running in the red, roughly,
yes.
By MLR math.
And their operating income shows it.
So, yeah. Exactly. And so the problem just compounds, and that's why you've seen them doing these drastic measures like SARS and making all these plans suppressed and non-commissionable, because essentially all the business that they're adding is just costing them, they're just bleeding out that money.
They're losing dollars for every enrollment, yes.
So I think everybody universally agrees that the MLR formula and the MLR definitely needs to be addressed. I think that's going to be, if I was to, talk to Dr. Oz and RFK Direct, it would be like, hey, we've got to reevaluate how we're doing this MLR.
Well, and I also think that they need to reevaluate what expenses can be considered towards the 85% and the other, because in the 15, the administrative services. And that was even one thing that they, in ways, attacked in this call letter too, is even allowing less of those quality measures in stars to be allowed in the 15%. Anyways.
Correct. And famously, just so all you agents know, our commissions and FMO overrides and broker payments are factored into the MLRs.
And they fall into the 15% category. So when 85 and 15, so 85 cents on the dollar needs to go into plan design, to consumer benefits. 15% can go to administration. Broker commissions and fees and FMOs fall under the 15. I've said for many years, you could really recategorize services that we provide and, reclassify that into the 85. Now, there's not been a big push for any of that, but of course I would advocate for that. The other thing that was kind of a little grenade that they threw in like one little sentence, and a few people caught on to it, and you know what I'm talking about, is
mentioned it yesterday.
They mentioned it's like, we are issuing a request for information on potential policies that CMS could adopt regarding how the MA and Part D MLRs are calculated in order to enable policymakers to address concerns surrounding vertical integration in MA and Part D. So they're
vertical integration.
So they're saying like, hey, we're watching this, like this is on our radar, like we're concerned about the vertical integration, and by that it's by having one umbrella or one entity who owns the PBM, who owns the hospital facility, who owns the diagnostic facility, who owns the anyways, kind of owns the risk management.
Just to simplify it, is we've been talking about some of these carriers like United Healthcare, who owns a lot of the downline distribution and services and ecosystem. And so, they're able to weather these storms a little bit better. I mean, ran very well, obviously, and they've made some very smart decisions. But essentially, when money's passing from the left hand to the right hand, and it all goes back into the the stock price, they're able to manage that ecosystem a lot better than somebody who's just functioning as an insurer, and who doesn't have that downline vertical integration. And that seems like a scary thing to regulate. As we've talked about, they've been very good at managing horizontal integration and acquisitions and monopolies that way. But these vertical integrations, where we've seen go deep on the healthcare systems, and where you have the insurers own the healthcare group and the doctors and the providers.
Yeah, and from a business perspective, you go, hey, we have X amount of members going to access, dialysis services over here at like DaVita, right, or wherever. and hey, and we're being billed these at exorbitant amounts, and they have let's say a 20% profit margin on that, and we're being billed to the millions. Why don't we just buy that? And again, we can basically bill ourselves and make that 20% profit margin, because we're already sending the whole panel is essentially our insurance membership anyway. I mean, it's a smart move, and there's nothing illegal about it. It's just, it's very common in business, but again, they've not done a great job in preventing any of that. And they're just basically now saying, we want to kind of find ways to look into this vertical
and the
integration.
theory of being able to regulate and factor in how there would be disproportionate advantages to the vertical integration, and then being able to effectively calculate and build that into an MLR calculation seems extremely difficult,
But let me give you perspective. I think United Healthcare right now is like 82 to 85 MLR, somewhere in there. I think that's their MLR. So,
yeah. Well, there's a reason why their stock price is crushing it, and everybody else is not.
Yep. So enough there. I just thought we would mention that because...
Well, we could, briefly, they do talk about the financial impact on it. And the financial impact is, their quick estimation is about $100 million per carrier in lost revenue on the MA side, and about $32 million on the Part D side. So that's just, again, you start talking out hundreds of millions of dollars in potential lost revenue to carriers on average. And again, where we're already at this year, those things, seem bleak. Those things, if I'm a carrier, I'm just going, man, things keep getting worse. The hits keep coming.
I'm having to pull up my doc because since yesterday, my iPad did a wonderful update. So
yeah, so the 14th was, they talked about the Medicare transaction facilitator requirements for network pharmacy agreements. So they're kind of coming at the PBMs a little bit there. I didn't do a ton of research on that, of all the things that I feel like could be examined, and I think will be examined in the new administration. I think some of these PBM arrangements are definitely going to be on the radar and looking at how some of these PBMs function. Do you have any thoughts there on that, or?
I actually took notes that I wasn't educated enough on the PBMs really, and I haven't dug in enough to really understand that. But of course, I think that they've been very critical, of course, of the PBMs and taking the rebates. And in theory, when a PBM negotiates lower prices, on drug purchasing price, they're supposed to pass those rebates and savings on to the consumer. And obviously that was something that was really looked at this last year, when PBMs were taking those rebates to the tune of hundreds of millions of dollars and then sending them off to the Caymans and other entities, and not actually passing them down to the consumer. So I do know that was something they were really looking at. So I'm not shocked that they're going to continue to dig into rules surrounding PBMs and what they can do with those negotiated rebates. But and also, I don't know what other restrictions they're going to put in place with their negotiations with pharmacy specifics. So that's one that I would tell you it's, I need to do a little more research on.
Yeah, the 15th thing was the enhancing the health equity analysis.
Yes, and utilization management.
Yeah, and I think that's going to be a hard one. That's probably not going to be a huge priority. Again, those are kind of nice, warm, fuzzy in feeling things, but in practicality, I think there's a lot of work there that goes into the, health equity. It has been a big buzzword over the past 2 years.
Yeah, it was social determinants of health, and then, of course, like health equity. And what they're really trying to say is they're going to be looking into more, which, I don't have bones or qualms about, but they're trying to really determine is, carriers do have some tools at their disposals as far as, prior auths, utilization management, restrictions. And what they're trying to determine is, are there any specific segments of the population that are being discriminatory upon, or that they're basically not able to use services as much as other groups. So when they're talking about health equity, they want to make sure that a person that's like a DSNP, for example, like a dual member that's below the federal poverty limit, if they need to access care, they have the same ability to access to somebody who's a higher income earner on on a traditional MA plan, for example, right? And that they're not being prior authed to death, so to speak, and that they're not getting access to the care that they need. And so I think that that's what they were trying to do is, and again, I haven't looked at the table, I will in a minute, but in order to kind of create committees and to kind of start digging in and looking into that in the real world, you then need somebody at the carriers to be appointed to that position to start digging into the data. And before, all those things were kind of aggregate and given as like a summary report to CMS on their different tools and, you know, their utilization and prior auths, et cetera, in a summary. And so now they're going to want to break it down very granularly into different categories. And to kind of get granular like that, it's going to require more resources from the carriers in order to do that. So while there's no cost to CMS for that, there is an administrative cost or burden put on each carrier.
Yeah.
So that's, you know, definitely one thing.
The next thing, and this is one that I think we should maybe spend a little bit of time talking about, because I think this is already knocking at the door and it's already entered in the business. Yeah, but you know, they do have guardrails for introducing AI, and I think that's something that, you know, both sides of the aisle are at least expressing interest in protecting. And you know, if you follow Elon Musk and Vivek and what they want to do with Doge and things like that, Elon is at least he talks about being a big proponent of limited AI and safe AI and things like that. And so I think that at least at this current time, I don't think anybody in government thinks that having AI tools and bots perform, you know, a vast majority or the majority of an enrollment is a good idea.
Right.
And, you know, this is coming very fast in the business because it's already fairly permeated throughout our business and all these different carriers and all these different call centers and things like that, and just tools in general. And we are meeting and talking to partners about this on almost a weekly basis. And we just had a partner that we met with last week who has an AI tool that's pretty sophisticated. And if, you know, of course the goal is to replicate real human interaction to the point where the consumer doesn't really know that they're talking to an AI bot, you know?
It reminds me of Silicon Valley. Do you remember when he creates Anton, or the son of Anton?
Yes.
And Dinesh is actually, he's like Guilfoyle, and he's like messaging back and forth, and then he sees him at the coffee machine. He's like,
yeah. And that was back years ago.
And he's like, you've been talking to my AI bot, you know? And he's like, he's all pissed. He was so offended. And he was enjoying the conversation so much and loved it. And then when he realized, he was just so mad and indignant when he found out it was AI.
Yeah. Well, I mean, with AI, as far as like, I think we're going to see guardrails onto how much of the portion of the enrollment process can be done for Medicare and ACA enrollments. And right now, you know, as everything is, it's way more of the wild, wild west on the ACA side of things.
Yep.
Because on the Medicare side of things, as we know, only a licensed agent can talk about any sort of specific plan benefits, go through an enrollment process. That individual has to be a live, licensed human being. And just procedurally with an AI bot, and I know, you know, proponents are going to argue that it's the same as or more helpful than somebody going to a website themselves and looking for information and filling it out and signing themselves up. But the whole purpose, especially with these AI bots that are replicating real human interaction, you're essentially deceiving these consumers, right? The proposed goal, if we're being honest, is to trick the beneficiary into thinking that you're actually talking to a real human being. Right. And you're not, you know?
Well, let's talk about it for more. I think the big concern too, that is a concern on the broker side and the interaction and the sales process with the consumer. I think more people are even concerned about the clinical side of it too, where you're going, in reality, we all want to feel about like healthcare, like your situation's personal, where ideally you would go to the doctor's office and it's a one-to-one where that doctor, or even if it's a PA or NP, whoever it is you're talking to, they're going to go through your health history, evaluate you as the patient, what's going on in your life, your needs, and diagnose you and give you a treatment plan based on what's going on. That's like ideal, right? And so I think that they're also concerned about AI being implemented broad scale to say male between the ages of 40, 45, this weight, this height, this ethnicity, this whatever. Here's the treatment plan where you're having AI essentially have all these different inputs and evaluating and making clinical decisions based on that modeling. And I think that's also one of the things that they're very concerned about as some of those models are already starting to pop up and replace a physician and an actual human-to-human treatment plan.
Well, I'll be honest. I'm more in favor of an AI tool and bot helping with like at least the introductory healthcare services than I am like an enrollment process, because there's financial bias on the enrollment process, and with the healthcare, a lot of it's efficiency. And I do think that, you know, there's a lot of primary care, and the way that our healthcare system is set up, there's a lot of front end waste where, you know, for example, for some reason in the United States, if you've got a UTI, it's a pain in the butt, you know, to go get medication and get a doctor's prescription to go get, you know, when you know, especially with a lot of like primary care stuff. When was the last time you went to a primary care doctor and you didn't know probably 95% of the reason why you were there? You're like, I've got strep throat, or I've got this or whatever. And it's very rare, I think, that people are like, well, actually, it's not that. It's this, you know?
Right.
And I think that from that standpoint, with like diagnosis and stuff like that, AI is actually going to be transformative in the healthcare space, and it's going to allow for more of like a nuanced next layer of care, and it's going to solve some of that basic stuff. But I'm talking about with like an enrollment perspective, there's going to be a financial implicit bias there. Yep. And I think that, you know, like we've been talking about the value of brokers and things like that, is we have a professional license with a state accreditation, a state license. We go through all these trainings, and ultimately a human being is responsible. You're on the hook. You have that fiduciary duty. You're the one saying, hey, I'm accepting a little bit of liability and a little bit of responsibility for making sure I do a good interaction with this client, and I place them and match them up with a plan that's going to best serve their needs, right? And there is that, you know, that reflect back to that person that does that. With AI, you know, you have these enrollment tools. It's like, well, ultimately, who would be responsible for somebody?
Well, and also think of it this way. It's the risk is much higher in the larger scale. You can have a broker who screws up one interaction and does a bad job and maybe recommends the wrong plan or does a poor job with one consumer. If you screw up the modeling in AI, you know, on something like that, it could, you know, the modeling on it could be wrong and affect hundreds of thousands of people just because of one input on the modeling, right? So, I mean, it's high risk, high reward kind of a thing. So, I agree with the guardrails.
Yeah, what would you like to see for at least how it affects distribution and agents and enrollments and things like that? What do you think is like a fair...
I think we could do a whole podcast episode talking about, you know, really AI and how we see it being used responsibly and leveraged in our industry and healthcare and everything else.
I think it's going to be put at guardrails as where it can pre-tee up or qualify or warm up a lead. And then at that point, it's got to essentially be transferred over to a real live human interaction, you know?
Correct.
And I do think that a lot of these companies, like the conversation I had the other day was, well, people call, they want to talk to a human. They don't want to get tricked. You know what I mean? They don't want to like feel like, and that's ultimately what I feel like some of these lead vendors and some of these tools are doing, is they're trying to circumvent and dupe these consumers. And there is a certain level of base level qualification work that I think these tools will do that we have used with like a large language model or a text format and things like that warm up and qualify leads. Yep. But at some point, a trusted real human being needs to have responsibility and walk you through those informed decisions.
Yeah, let's move on from the AI, because I could spend 30 minutes talking about it. But again, we're for the guardrails. For the record, you know, we use AI currently. We have it in different stacks and platforms, and you know, and obviously it's available. It's been really beneficial for us. It's been great.
We've been using AI in some form or fashion for 6 years.
Yep.
From, you know, the initial, before everybody even really, I mean, that was one of the keys to our early growth and early agent recruitment was automations that were AI that people didn't know were.
Yeah, we've been using AI for a lot of years, and it's great. And you know, and I don't think we abuse it. And I think we do it in a good way. And obviously, but I'm for some of these guardrails.
But now that pendulum swung so far the other way that I assume that everything is a bot or an AI or something like that, and that it's never
Funny story, we can even go through, and I'll even just say, like, Grace Topman, who's like a good, you know, industry friend of ours. You know, when you met her the first time, even, I think you were like, are you a bot? You know, on LinkedIn or something. And when we first connected, she's like, no, I'm like a real person. What are you talking about? Kind of a thing. Because we get so many different bots and things that message us all the time.
Yeah, your LinkedIn mail messages and things like that, and all these emails. Like, if it sounds intriguing, my first question back is always like, CAPTCHA verification. Are you a real human being?
Yeah.
You know, like
Exactly. So let's go through the next one here, and then I want to go through the costs before we run out of time. Promoting community-based services and enhancing transparency of in-home contractors. So for me, this is referencing things, of course, like Papa Pals, house calls, things of that nature where, again, I don't really have an issue with this one, of course, with if you think about how often, if you're a broker and how many times your client is contacted by different organizations and they're like, what the freak, do I have to do this person or have this nurse come to my home or have this evaluation done? I don't want to. Who is this person? Why do they want to do it? There's a lot of those providers a lot of times aren't listed in the provider directory, and they're also maybe not, I would say the broker community at large does not do a great job in explaining next steps and setting expectations after an enrollment. And so it's very normal for the carrier to follow up and try to establish a baseline, do house calls, or if you're using Papa Pals or something like that for help around your home, things like that. A lot of these people are not listed anywhere in providers with these carriers.
Correct. And I think there's also a safety and a security measure to that too, because I don't want to say the company because I don't want to get sued.
Yeah.
But or I'm not really sure if I'm saying it, if that's who I'm thinking of. But there was a famous case this year where one of the in-home workers, like a in-home service worker, did something bad, and then that kind of sends shockwaves through the industry because you really go, hold on a second, what are the qualifications for these individuals that are going out into the homes? How have they been vetted?
What's the screening?
Who are they?
Background?
What's the screening? Can I look them up? And, if I was going to send, a stranger out to our parents' house, I would want to know, who are they? Are they vetted? They're not a licensed doctor. They're not like, they might be some, guy with a hidden record that picked up a job because they were desperate, and you just want to make sure. So I think there's some good intent there. And that's one that I think, the carrier should have a little bit of responsibility to make sure that's clearly delineated with the registry, and you can look up. And if you're a company, that's doing that, one of these third-party companies, you should easily be able to provide records from who's going out and doing what, and have some sort of directory or registry where people can go look up. And you want to make sure you're not sending sex offenders out into the marketplace. I
don't think they've done a great job of checking and really screening those. In a lot of cases, you have college students who are the ones out doing some of these.
Yeah, and like the people doing, out committing fraud in the industry, you have just 2 or 3 bad actors or a handful of bad actors that do something like that sends shockwaves through the industry, and it's everybody reacts, and it's brutal for the industry. So it's
blown up. Yep. Well, so I'm going to go through each individual thing on this executive summary and talk about it. Before I do that, I wanted to mention too that, like always, or not like always, last year they literally put a severability clause in the call letter, which had not been done before again. And in legal jargon, severability means, hey, basically this whole agreement, if there's some element or component to this agreement that is not legal or does not comply with federal, local, any statutes, any other bodies, and this can't stand, it needs to be tossed out, everything else survives. Like that one thing is severed, but everything else stays there. And so, again, they just did that this last year. They put that in again, some severability into this call letter, which I think is annoying. But because they basically are saying, again, all these things, if they go through like we're proposing, we know we're going to be challenged on them legally. And now it's like you got to pick each battle and sue on each part individually. So I just wanted to mention that again in the call letter. And let's go through like 1 through whatever. So on number 1, like the vaccine cost sharing changes, with the CBO and the Medicare Trust Fund, they're saying the financial impact, we don't expect that these proposed regulatory changes will have an impact on the Medicare Trust Fund. I don't know if I agree that there's going to be absolutely no cost, because there's always a hidden cost administratively to do it. There's a lot of moving parts to how they want to move over the what is that immunization organization that they were talking about again?
The ACIP, the Advisory Committee on Immunization Practices.
Yes.
Well, I mean, look, we just know this because this has been in the news. There's the vaccine schedule it's not shrinking. Right. It's increased exponentially over the past 20 years. And so if you just, go by trends, you're going to say, well, they're going to be recommending more vaccines, which if the fund is paying for and the carriers are reimbursing and paying for more of those, how does that not have a cost increase?
So, and maybe the Medicare Trust Fund says it doesn't impact us, but if you increase the number of vaccines that are accepted that let's say the MA organization or even original Medicare is paying for, let's say you have 3 on the schedule and now you have 6, I don't know, that math doesn't math to me to where you go, oh yeah, that cost us nothing.
Well, we didn't read the details of it. Maybe they're trying to say like, hey, if we, vaccinate X amount of these diseases and illnesses, it lowers X amount of cost on the back end of the fund and it nets out, or things like that. Preventative offsets the cost on the back end. Or
they just are making some modeling and assumptions that it's going to reduce X amount of sickness, and therefore, I don't know. I haven't looked into the math, but I question that. The insulin cost share changes, like the biggest thing, of course, they are estimating that it's going to increase the federal cost by approximately $1.2 billion. From over the next basically 10 years with that. I think that's way, way, way low. But all they're really doing, again, is if you remember, insulins are set at the $35 anyway, but by putting in like the lesser of, with that 25% of the negotiated price, that's going to reduce some people's copay, and it's going to increase some of that cost sharing. So I think really low. I don't think that's accurate.
Yeah, I still think even at $35, I'm not a pharmaceutical expert, but if I remember right, the cost to produce those insulin injections is just a couple of dollars. So they're still fairly profitable at the $35, and so maybe that's what they're thinking too is.
Well, and we've come a long way, dude. I would just say this too, like it's been a few years since I've been selling, but I remember Lantus being like a tier 4, formulary, and people were hitting the gap in the donut hole all the time, and you were an $88 copay on some of your insulins. And so to go from where that was, where a diabetic, you almost instantaneously knew you're going to hit the gap. And so to be where we were years ago to where now it's a $35 copay on your insulins, I think that's leaps and bounds ahead of where we were years ago.
Yeah, 10 years ago, that was the whole game, managing when you'd hit the coverage gap and how you'd hit your max out of pocket on that if you took any sort of name brand, insulin. I'm
not trying to not throw love to the diabetics out there, but I'm saying they've gotten a lot of attention and love and, a lot of strides their way in the last few years. And so if, I think that if there's other objectives, if again, I'm in a position where I'm making decisions, I'm going to say, hey, let's shift some of the dollars and the focus and the things to then maybe the mental health or something instead of the diabetics, but anyhow, the Medicare prescription plan payment program, we do not anticipate any cost to Medicare Trust Fund, but I can tell you that's brutal for the carriers. If you start increasing more and more of these individuals who are on MAPD plans and PDPs to the carriers, to where now you're boosting the people who are raising their hands saying, yes, I want to get put on a flat payment program throughout the year, and you, Aetna or Humana or whoever needs to, and I'm going to start filling my meds January, February, March, and they're really expensive, and I have thousands of dollars in drug costs, and I have a flat copayment all year long. From a cash flow management perspective and that capital, that's brutal, especially when you have millions of members. And so, again, I think that's really tough for Medicare to put onto the carriers with all the other pains and challenges and reimbursement and compensation right now. And you're even looking at all these healthcare companies right now. Most of them are not murdering it with their earnings reports and their quarterlies.
It's just capital intensive. They just have to hold way more cash in their reserves, and they can't deploy it into growth and other initiatives and service. They're just having to sit on a bag of cash.
Exactly, to fund it, and that's brutal. And I think that's very, very short-sighted of them. So I would just put that in there. The Part D coverage of anti-obesity medications. This one, we estimate over a 10-year period, it would increase the federal cost by $24.8 billion due to expanded Part D, and $14.8 billion to expanded Medicaid. If implemented, I would double those numbers. I mean, personally, I know
if not 10x them.
Yeah, and I talked to another person in our office today who was like, yeah, but Ozempic's slated to be a generic on 2026, and I was like, yeah, but they always try to extend those. There's lawsuits about them not going generic, and even when they do go generic, is the generic price $250 versus $800, plus then a new GLP-1 or semaglutide comes out, and then it's,
and already there's all these boutique wellness clinics and things like that where you can buy versions or generics or compounds of these GLP-1s and things like that. Yeah, they're still freaking way expensive, so
being generic might be, this is generic for 500 instead of 800 or whatever. So that's not going to solve it. And so I think that that's way, way, way low. I don't really want to get into a deep conversation of the
hypothetical costs.
Because they're like, it's always this theory of like, I feel like that meme of Zach Galifianakis with like all the numbers and things swirling, like that's what I think of.
It's like thinking
when you're trying to forecast of like, well, if we did solve their obesity though, and we lowered their cholesterol and we lowered their high blood pressure and we did all this, would we save this versus the net? It's
that's what these guys do on the meme. And then they're like, and we estimate that there's going to be no cost to the fund. After they
I just go, I might as well just be a weatherman, a meteorologist, and be doing that. But anyways, so I think that's one that I don't necessarily agree with. The promoting informed choice, the format provider directories for the plan finder. Of course, the proposed changes will not affect the Medicare Trust Fund. The paperwork burden is $500,000 annually. I think that's $500,000 annually on their end, on CMS, or maybe more, to be honest with you. If you understand technology, that's, them having a whole team of people scoping out like their fields, API datas, changing formatting, adding for new fields. But the bigger thing is every single one of those Part D organizations and MA organizations out there, for them to go through and also scope that out on their end and provide that, you're increasing those administrative costs with all those carriers again. Great idea. You do it though, in an environment where you're already cutting payments and reimbursement rates. Those two things don't jive and don't align. Promoting informed choice, expand agent and broker requirements regarding the Medicare savings programs, extra help and Medigap. Oh, there's no changes to the Medicare Trust Fund, but sure making the broker's life hell.
Yeah,
on
and the carriers.
Yep, that one's ugly. We already covered that in the first episode, so I don't want to spend a lot of time rehashing that one, but definitely to say we're in opposition of it. Promoting informed choice, enhancing review and marketing communications. We already covered this at length. They are saying that we estimate it'll create an additional paperwork of $3.87 million for Medicare Advantage organizations. I'm like, are you talking $3.87 million for one of them? Yeah. Because I got to be honest, the compliance departments and the caliber of people you need to bring into those organizations and systems perspective, it's going to be a lot more than $3.87 million for all these MA companies to monitor. Just for us, when we have to submit all of our branding and materials for social media ads and scripting and newsletters, email blasts. I mean, you start going through every bit of marketing and communications to client retention letters to everything that you're having to submit. And that's one agency. And you say, we have thousands of agents and we're having to aggregate pieces from our downline distribution and send them off to 9 carriers to see them to opt in. We're talking $3.87 million wouldn't even cover the amount of cost for FMOs in the supply chain for that.
Yeah, I mean, this one's just, if you go read the details of it, it's very, very bad and very brutal for agents about like permissions and acceptance. And it's basically like any sort of outreach or communication or any sort of education you do is going to fall under the guise of you're essentially attempting to market, and you've got to get all these permissions, and it's just more and more hoops to jump through. And so, yeah,
and by the way, the more they do it, the more that the brokers are the bad guys and they're non-compliant. Right?
Yeah, I mean, overall, as we keep going through the financial impact, they're just looking at all they're analyzing is this going to be a cost to the Medicare fund? And there's costs to all of these things.
But it doesn't really matter. What I'm trying to say is it doesn't matter if there's a cost to the Medicare Trust Fund. That's what they look at. But then there's costs down the supply chain to the carrier, to the FMO, to the agent, who ultimately, by the time it rolls down to the consumer in the marketplace, they're severely impacted because every one of these steps in the supply chain is impacted and makes their adjustments. And then that consumer, who, again, we all want to serve, is very, very impacted by all these things that CMS says, well, we don't think this is going to affect the trust fund.
Well, and just there has been a psychological burden on the agents and the carriers and things like that, and the community that's actually, doing the service work, helping these consumers. And all these additional rules, like we said, we saw a little bit of like freak out and panic from some agents and agencies yesterday and today on posts and videos and things like that. And it's just, we don't think that there's need or to worry about things like that, but it's just, you're creating such a burden that it's really been mentally defeating for a lot of these agents and agencies. And I will say that we've already seen a lot of agents exit the business. And this AEP, if you were not a well-prepared, smart, sophisticated agent, I'm seeing a lot of agents complaining about this AEP was very defeating for them, chasing their tail. And then you look at it and go, man, we've got, more regs and more difficulties coming down the pipe. They're making it very, very difficult for the independent agents out there to do this business.
Well, and there's a couple other things that I want. We'll run out of time like always, but I think the other thing, if you go through this again, I'm encouraging all the agents to at least read the executive summary and go through the table and read a few pages on this call letter. Medical loss ratio, number 13, they're estimating that it's going to basically reduce payments to MA organizations by about $101 million. But then, so basically they're saying, yes, with our new formula of MLR, we are estimating to pay them about $101 million less. I think that's way off. It's going to be far more than that. I mean, you even think about the lawsuits that just happened. You had, I can't remember off the top of my head because I didn't prep, the Humana lawsuit in the United. How much was it? 60, 70 million off of one phone call and one metric. You know what I mean? So for them to say, hey, it's only going to be $101 million in reduced payments to carriers, I think is way off. And then their audit process in being able to pull back $32 million annually, far more than that. Because again, going back to processes in the call letter for 2025, there wasn't a limit like before when they would audit. And but if they didn't audit, and let's say they found a discrepancy in the STARS data or the HEDIS data, they would go claw back those particular dollars that had been given to the carrier. Now, with the new process, there wasn't a limitation. So if they found that discrepancy in the audit, they would pull that across the full amount of membership. So they would essentially say, hey, instead of peeling back, these dollars of the 300 members that we audited, this particular plan has 25,000 members. We're going to apply that logic across all 25,000. So for them to say, hey, we're going to bring back 32 million, there's far more that they could claw back. So I don't like that from the perspective that it creates a lot more destabilization in the Medicare Advantage companies and the PDP companies from that perspective.
Yeah, I think, overall, if I was an agent, I would not freak out. If I was a carrier, I would not freak out. I do feel like we're on an upward trajectory of the industry again, and it is going to take next year, like we've been talking about, is pretty well baked. It doesn't matter what happens with the administration or the cabinet picks and things like that. We're going to see still a little bit of some rough waters next year.
Yep.
And then I think things are going to level out. I'm very interested to see, how the Make America Healthy initiative actually applies down and trickles on down through CMS and through Health and Human Services and kind of like the rules and the MLRs and the calculations and things like that. Because I would imagine there's going to be some tweakings of the MLRs and the STARS and the HEDIS measures and the reimbursement rates on other certain behaviors and protocols and things like that are going to be, just a different philosophy of healthcare and things like that. So I expect those things to kind of be introduced over the next 3 years as well.
Before we wrap, I'm not to throw a grenade into everything before we cut off the episode, but the other thing that brokers were already kind of tuning into, their Control F, searching documents and looking at compensation in that call letter, of course, is there was a proposal, and I don't know if you read into this, there was a proposal to pay a flat rate to brokers and not pay on Medicare Advantage sales like a new to Medicare and a renewal commission. Did you read into that one?
I didn't get there yet.
So yeah, there's a proposal in there too to not pay brokers to one flat fee or commission, because the argument was that brokers spend a disproportionate amount of time, trying to track and serve T65s versus, a regular Medicare beneficiary. And so it's going back to equality. It basically, they would spend their time doing that. The counterpoint, of course, is that when somebody, of course, is coming on to Medicare, they have 101 questions. And sometimes, and if you're a good broker, your phone call or your face-to-face visit sometimes is 2 to 3 hours going through all the basics and the educational aspect of it versus somebody who's been on Medicare for 10 years, navigates the system pretty well, and your really good thorough appointment is maybe 15 to 20 minutes on the short end to 45 minutes is pretty common. But, again, that's why there's a payment difference there. But again, that's going back to people need to understand the why. And there's a lot more typically service work initially in setting somebody up who's turning 65. So again, brokers are really up in arms about that. I'm just going to say again, everything we've been talking about, we're just going through the proposals. We're just talking about them. We're hashing out this call letter. I don't think at this point in time, we really need to be concerned about any of these things really going through. I think read about it, research it, educate yourself. This is, I think, them with Becerra and this administration trying to show the initiatives that they want to get completed. And I think the new administration will come in with their framework and objectives, can do something very, very different. And both sides want to be able to finger point to what they wanted to accomplish and why they couldn't get it done. So I think stay tuned for the real come February and March, in my opinion.
Yeah. Overall, this was not, obviously we didn't expect it to be near as impactful as last year's call letter, and there's some good ideas. The actual implementation of a lot of those things is a little bit, fantastical at this current point and a little bit hard to achieve. And it'll be really interesting to see how, things play out over the next 3 or 4 months. It'll be interesting to see how the new DOGE department goes to the Health and Human Services budget and tries to reorg that and things like that. That'll be very interesting. If I was a carrier, that's what I would be keying into as to what dollars in the ecosystem are being considered, wasteful or unnecessary. And I think, in a perfect world, anything that is that would be reallocated into these MLRs or these reimbursement rates that are to promote good health care across the system. So it'll be interesting to see how that all plays out.
Yep. But more to come. We'll kind of we don't want to bore you all to death, but by next week, we'll probably have read and ingested a lot more of that information. I'm sure there's a few more nuggets that we'll kind of, the devil's in the details. When I'm usually about page 356 in, there will be things that catch my attention that we'll probably want to talk about and go through.
Yeah, the next podcast we should talk about AEP wrap up, who won AEP, kind of where things trended.
We'll be doing, so stay tuned next week. We'll probably actually go through, take a hot minute for my own, talking about mental health, my own mental health of reading a 700-page call letter. We'll probably be going through something that's a little bit more fun and that kind of year-end planning cycle and next year and how to do that. And so plan on that for next week. And then we'll probably maybe go back to, who won AEP and, more call letter stuff ahead.
Yep, absolutely. Happy Thanksgiving, everybody.